Great. We are live, but as I said, guys, we'll give everyone a chance to kind of join on because the webinar doesn't quite go live with Facebook Live, I think, to start with. So here we go. Event started. Let's see. Live in an event. Brilliant. People are starting to join us. Welcome. We're giving you some time to join us for now. Yeah. Great. Looks like everyone's managing to join okay, but we'll give everyone like another minute or so to just kind of join in so we can make sure we allow that. Yeah. Right. Hi, Mark. Thanks for letting us know you're watching. It's good. Great. Right. I think we'll make a start then. And then for those of you that do join partway through, you won't really have missed much to start with. So everyone, thank you for joining us this evening. I hope, you've got a cup of tea and you're comfortable to just join us really for this chat. The title is obviously Under Pressure. So we're here tonight to really talk about bicycle ergonomics, but see how that relates to male pelvic pathology. So just a little bit of an intro and some kind of housekeeping, if you like. We've got Tim and me. And we are basically sports physios. You don't really want to know too much about us, so it's a little bit repetitive with this. But we do deal a lot with cycling medicine and cycling related injuries. But we are joined tonight by Ove Indergaard. Ove, have I said that right?
Ove.
Ove. Oh no, Tim's giving me a thumbs up. I didn't. Okay, Ove Indergaard. So Ove, I'll do my best to give a bit of background on you, but please feel free to fill in. So Ove is also a physiotherapist, a trio of physios tonight, and has a background working in elite sport, but you've now opened your own practice, and you're developing a little bit of a niche pathway, really, it sounds like, for some clients that are experiencing erectile dysfunction. So you're going to talk to us about that later, right?
Yeah, I mean, the practice has been open for a good number of years now. The ED Clinics is a network, is a partnership with some other healthcare practitioners to serve a very much underserved population who's struggling with men's health issues, ED being one of them.
Brilliant, thank you. So some learning objectives just for tonight and things we're going to talk through. So I'm going to hand over to Tim to go through these. Guys, if you do have questions and things throughout as we go, please feel free to post them into the comments. And if they're relevant and we can feed them into that channel at the time and it works really well, then great. And if they don't, then we can certainly run through them at the end. So you ready, Tim? Tim, to go through all this?
Yeah, and I'll just say that we are also all cyclists and triathletes ourselves. So I know, Ove, you've not raced in a while now, but you are still a triathlete. Once a triathlete.
Yeah, I've got a few races under my belt.
So, we are talking both from the medical side of things as well as the athlete side of things. So, yeah, so what we're going to do is just do a bit of a recap. We did do a very similar talk a little while ago, looking at the female pelvis and interaction with the saddle. So this is now giving our male slant to it. So we'll go through a little bit of the anatomy, the underpinning anatomy that we need to be thinking about. And then, yeah, Bianca, do you want to slide on through? Going through our sort of main common and maybe sort of uncommon pathologies and problems that may present. And then think about, well, what can we do as bike fitters, or what can we be doing as therapists to deal with these common problems that men are going to present with? And I guess the main thing we want to get is a discussion point going. So getting us talking to our clients and making sure that people realize that pain, discomfort, numbness, erectile dysfunction, things like that, these are not normal. You should not get this from riding a bike. but it is also very, very common. So there's the sort of classic paper, seminal paper really, the vicious cycling. So this was published back in 2004, 2005. And this was coming from the urologist's standpoint. So they were seeing a lot of people coming into their clinics with sort of urinary and genital problems because of cycling. So this really started the conversation regarding that this is a common problem and it needs addressing. And there's been a wealth of literature since which has explored this in a little bit more detail. But we in the maybe sort of bike fitting world have sort of lagged behind in what we then do to address that. So we're going to go through a few of the common problems that you may or may not be seeing in your clinic. And again, as Bianca said there, please do pop some comments in the chat box as to maybe some of the things you've seen in clinic and may or may not have been clear about how you address those.
So, interesting standpoint there, Tim, is there's a lot of debate, and Ove, I don't know if you have any opinions on this as well, about whether there are anatomical differences between the male and the female pelvis.
I think they can be. Obviously, the variance is quite great. It's not something that I've looked massively into, to be fair, in terms of the pelvic health, at least. And certainly for the ED, I don't think, well, women do get also chronic pelvic pain for sure, and sometimes for several similar reasons. But yeah, I'm not entirely sure whether that has a huge difference. I don't know what your experience on it is. Obviously, it has a massive implication for how you fit somebody onto the bike.
Yeah, definitely. In terms of your opinion, Tim, do you tend to see like the typical male and the typical female pelvis?
No, I mean it's almost that whole thing about female specific bikes and male specific bikes. There's no such thing. It's about having the right shape bike, right size bike for you and your anatomy. So yes, we have trends. So generally, the female pelvis is going to be wider than the male pelvis, but that's not always the case. So you can have men with very wide pelvises and very wide sit bones, and you can have women with very narrow sit bones. So it's about understanding the person in front of you and not lumping them in the category of, oh, because you're a man, you're going to have a narrow pelvis, you can be riding a narrow saddle. That may not be the case. It might be they have actually got a very wide pelvis.
Agreed. You've got to treat the individual. Yeah. I think, like, you know, there are like a lot of kind of research papers that do look into this. And yes, as you say, you will see trends. And on the whole, you can say this might apply to X% of the population, but not everyone fits into those boxes all the time. And sometimes those constraints that are put on people, they almost feel like they should fit into that box. And when they don't, they then don't know what to do or perhaps how to resolve their issue, really. So we know about the bony kind of anatomy, and we'll say that, yeah, okay, statistically, there can be some differences between males and females, not always, but there can be. But what about, you know, the soft tissue and the internal pelvic anatomy that pertains to males?
So
yeah, sorry, did you want me to cover that? So yeah, the pudendal nerve obviously comes out of the sacral plexus between S2 and S4, and the important thing here is that it supplies both the sensory and the motor aspects within both the perineum and into the penile area. It comes out of the greater sciatic foramen and before it passes underneath the piriformis muscle before it then goes back into the inferior sciatic foramen and then joins the other side and forms with the pudendal artery and the vein what's called Alcock's canal, which is then supplies both the blood flow and the nerve sensation and motor function to a lot of the perineal muscles, the lower pelvic floor, and also the sensation to the penis, and has a very, very important function in terms of both getting and maintaining function for men.
So Tim, how can the pudendal nerve like really relate to pathology in cyclists?
So what we're seeing here is essentially pressure on that perineum, so on that soft tissue. So this is where our classic bike seat shape, that bike saddle shape, where you've got a narrow nose. And if the rider is sitting on that nose, you've got a lot of pressure going through that soft tissue, which might then be creating a compression force on the pudendal nerve, on the artery, which is then reducing blood flow or reducing neural signals through to the penis. And obviously, depending on the individual's anatomy, will depend on how much pressure is being placed on the nerve, the blood vessels, things like this. So this is where we then think about our different riding postures. So if we think about sitting nice and tall, nice and upright, if you're sitting on that sort of maybe a hard seat, you can feel that pressure going through your sit bones, your ischial tuberosities. But our riding postures vary. So we vary from this nice upright sitting posture through to where we're then rotating forward, maybe into a triathlon or a time trial type position. And we rotate that pelvis further forward, as you can see to the right of your screen. And we end up putting pressure on the bony arch coming through to the front, the ischial ramus and the pubic rami, but also putting more and more pressure onto the perineum. So this is where you might have a rider who says that they're fine when they're just sat up and they're on the hoods, but when they go down on the drops or they go onto some aero bars, that's when they start to get problems. So it's understanding how that pelvis is aligned with the saddle, and therefore what kind of alignment and what kind of pressure contact areas are going through that saddle. So as we got up on the screen here now, we've got our sort of normal ranges here. And this is giving you an idea about sort of how much kind of knee extension, so how straight that leg is getting, how much that forward lean is happening at the hips and thus through the back there. But all of these are going to have a part to play in how much pressure is going through that saddle. For example, if you've got somebody whose saddle is maybe a little bit too high and they're stretching for the bottom of that pedal stroke, we're going to get a lot more compression going through that seat and through that saddle. If you've got somebody who's got a very aggressive sort of low position and a lower back angle, then again, that's going to create more pressure going through maybe the front of the saddle and through that perineum, compared to somebody who's maybe sat up a little more upright and can therefore take that pressure off the perineum. Do you want to add to that?
Yeah. We don't really see this as well. I mean, Tim, you're familiar with saddle pressure mapping, but I don't think you've got access to it in clinic, have you?
No, I don't use it in clinic myself, no.
So Ove, this might be new to you as well, but for those of you that are watching, there are a number of companies that exist on the market that allow you to obtain pressure mapping software and hardware to actually assess where that individual cyclist is loading on the saddle. So there is quite a ton of research on this. Generally, there are some trends, just like there are again with like pelvis width, for example. So when we look at male cyclists and female cyclists, we may see that actually female cyclists can need a wider saddle in order to take the pressure off some of the soft tissue, whilst males overall can have a narrower saddle. But as Tim just mentioned, it comes back to lots of other parameters. It's not just about the saddle and where that tissue loading comes from. It's about what position do you want to be in. If you're more upright, you're generally going to need a different shaped and perhaps a wider saddle versus when you are riding in a more aggressive and forward rotated position at the pelvis. So when it actually comes to looking at these things, we can map that individual and find out why they're having problems. Do they relate to the issues that they're presenting with? I.e., is it a bike-related issue, a positional issue, or is it actually that there might be something off the bike that's happening as well that doesn't really match with the symptoms that they're describing? And when it comes to saddle issues, really, there's a lot of a lot of contributing factors for each cyclist, really. So Tim, just coming back to what you were saying about the bike position, do you want to talk us through some of these things that might occur at the saddle interface and relate to some of those pathologies?
Yeah, so the first one there we got down is pressure. So we've got essentially 3 points of contact on the bike: our feet, our hands, and then the saddle itself. So some people, for example, are putting more pressure through the saddle because they're not maybe coming forward and loading the front end and taking weight through their hands. So the saddle is taking more. You get some people who maybe more novice riders who are not actually pushing very hard on the pedals. They're very soft through the pedal, and therefore their feet is taking more of their body weight, compared to people who are putting a bit more load through the pedals, and therefore actually lifting themselves up off the saddle, relatively speaking. So we can see more pressure in people who are sat upright and pedaling maybe a little bit more gently, compared to people who are leaning forward a little bit more and putting more pressure through the pedals. Then we're thinking about obviously the type of saddle, whether it's a very firm saddle or whether it's a more padded saddle, and that will vary whether we've got a smaller contact area of pressure or maybe a wider contact area of pressure with a softer saddle where they're sinking into it. And that's where sometimes we see more padding not being a good thing, because you can create a wider pressure area as opposed to maybe one small area. That does play a part in some people. So then I mentioned earlier there about the saddle height, and that can therefore cause pressure as well. But the other thing with saddle height is if we go too high, the common thing we see is the pelvis starts to rock because people are reaching for the bottom of the pedal stroke. Or sometimes if they've got maybe stiff hips and they've got longer cranks, is you see people hitching their hip over the top of the pedal stroke, and again causing that rocking motion in the saddle. And that's where we then start to see this friction and literally just rubbing that skin. And that can be things like even just causing saddle sores because of that friction. We can be getting issues with hair follicles where you're tugging on that hair follicle all the time and getting then sort of material getting pulled down into that hair follicle, causing infections. So again, that's where we're then thinking about the stability in that saddle. And then environmentally, it can be even things like, are you wearing clean bib shorts? Are you washing your bib shorts in between rides? Are you finishing your ride and then spending the next 3 hours just wandering around in your bib shorts with these kind of dirty, smelly, sweaty shorts on? And if you've done a long ride and got very sweaty, that's a lot of sort of essentially salt crystals that are rubbing on your skin and causing all this kind of irritation. We could even think about, are you shaving or waxing, and how, if you are shaving your legs, how far are you going? And even these things can have an impact up to your saddle interface.
Yeah, and I think temperature as well, Tim. Found that temperature can be something that people say. They say, oh, it's fine, but then they just went somewhere that was really hot, and perhaps they have 2 out of 3 things. Yeah.
Hey, can I add some bits about obviously blood flow and everything? So we're talking about pressure, which seems to be a big factor, certainly in terms of both numbness and erectile dysfunction too. And they found that by sitting on your saddle, that there can be up to about 70% occlusion of blood flow into your penis. Which is quite a lot. And then, so that was one thing, but then they started looking at different saddle types, which I think is obviously very relevant for what we're doing today. And they looked at a narrow saddle, and that caused around about a 70% reduction in flow. Obviously, if you had a wider saddle, that increased the blood flow with about 50%. But then they looked at sitting more upright as well, and sitting more upright in your riding style, as if you were on a mountain bike, for instance, compared to a road bike, then you would have poorer blood flow, purely because the downward pressure is higher. They also looked at these specialized saddles, you know, with the cutout in the middle, which was popular a while back. I don't know if they are that popular these days, but then that was actually no difference. It still had 70% occlusion of blood pressure or blood flow into the penis. But the one that they did find was the more like the Adamo saddles with the two prongs, which then took that problem completely away. Which is really, really important. But they also found that if you had a really flexible back, you could accommodate for most of that. And if your back was flexible, then suddenly the pressure on the saddle wasn't so important either.
Yeah, definitely. It gives you a wider parameter, I think, in which to absorb. But the Cell S&P saddles are the same. So have you seen those saddles, Uwe?
There was, sorry?
The Cell S&P saddles.
Yes, I have, yeah.
Yeah, so they've got a really, really big cutout. And, you know, having a big cutout can create some additional challenges and some additional problems. So again, it's finding out what your person is complaining about. And like you say, if the issue is blood flow and it's causing symptoms pertaining to that, then, you know, you've got to get a cutout on there, really. So.
I think it comes back to what Tim was saying earlier, you know, the pelvic anatomy is so individual that often, you know, what I see in the clients that come and see me, they have tried, well, not just for ED, but cyclists in general, they've tried 10 different saddles and they just can't get comfortable, and they're very confused in terms of what is the best fit for them.
Yeah, agreed.
And yeah, I mean, on that point, Bianca, you're well aware of my history, my many broken bones. I ride my TT bike on a standard narrow nose saddle, and I will sit on my perineum and I have no problems. So, you know, it's not always that the case that if you in that rotated position that you're going to get problems, which is obviously my pelvis is all smashed up and got bones all out of position and so on and so forth, which is somehow how I managed to sit in that position without any problems. So it's all about that individual. But Uwe, you were talking off camera about even the duration that these reduced blood flows are lasting for. And you mentioned one paper that said they saw reductions for several days after a long sort of sportive ride.
Yeah, no, this was some of the initial research that was presented, and it was already in a review paper. So I don't know the original one, but it was from a sportive that I know quite well. It's the Trondheim Oslo sportive back in Norway. And it's about a 6-hour ride with some very steep hills. And afterwards, oh God, what was it? I think there was probably about like 2 weeks worth of erectile dysfunction after the ride in some people. Now, obviously, the incidence is around about 13% in that group. And overall, from long distance cyclists, the incidence is somewhere between 6 and 13% from what I've seen in the research. Of people actually developing erectile dysfunction after a single long distance ride, which is quite staggering, really.
We've had a request for some of the papers. Actually, is this something that you could maybe provide afterwards, and we can share with everyone?
Yeah, I think I see Daniel there has asked about the back flexibility. Again, that was in one of the review papers that I've presented later. I will present later.
Excellent. Just before we move on as well, Mark has mentioned that he said presumably once the fit is achieved in terms of angles and height, once you know the width of a specific person's pelvis, the expected position of the ischium from the pressure maps, you can pretty much narrow down a likely selection of suitable saddles. Yeah, I think to a point, Mark, definitely like if you do need to know the position is approximately right for an individual before you select a saddle, because you do get this a lot. You get people who self-refer and actually receive referrals from professionals. And I'm sure, Tim, you see the same. And actually, the opinion is that there is a problem with the saddle. But actually, as Tim said, if the saddle's too high, actually you may then have a saddle that becomes suddenly far more comfortable and actually the symptoms are alleviated. So you do need to get the fit position roughly dialed in, but you may find, dependent on, you can't just change a saddle for another saddle then, because you may sit in a slightly different position on that saddle, for example. But it does mean that, yes, you can narrow down some potential saddles. And there's a bit of a myth on choosing saddles as well, which we can kind of talk about a little bit more later. But I mean, I don't know how you feel about it, Tim, but sit bone width does not always, or ischial tuberosity width does not always equate to the same width saddle.
Yeah, so we've got lots of formula out there on maybe how to pick a saddle, from Physique's simplified how flexible is your back, and you touch your toes, your knees, or barely bend forward at all. You know, sort of bull, chameleon, and snake, isn't it? Well, through to measuring your inseam and your thigh circumference and your sit bone width, and plugging all that in and trying to come up with a saddle choice. But it really comes down to sit on the saddle and is it comfortable, and we can use pressure mapping in order to identify particular hotspots and things like that. But it still comes down to that very simple thing of, is it comfortable? And yes, I'll quite often get people coming to me. I've got a wide range of test saddles in my clinic, and people are coming to me thinking, yeah, I want to try those saddles because what I'm on isn't comfortable. I'm getting these problems. We sort the position out and we send them away on exactly the same saddle they came in on, because once you sort out the position, actually that's the main battle. So yeah, that just reinforces what you were saying there, Bianca.
There are quite a lot of different pathologies that can manifest on the bike as well. They can be different in males compared to females, just because, again, of the way the anatomy is derived, or the external anatomy, certainly, because you know, for females, the vulva might be fleshier and it might have more external protrusion, which can put it at risk of perhaps more like soft tissue lacerations, abrasions, etc. But you know, with males, I mean, Tim, do you see a lot of saddle sores and sort of dermatological based issues? Because I mean, I see quite a few really, a lot where the skin has broken down as well, but it's just in different areas.
That's it. I mean, I even had a chap in not so long ago who had even had multiple surgeries because of repeated saddle sores and breaking down, and the amount of steroid creams he'd used over the years had just weakened his skin even further. So yeah, I mean, that is a problem that can end up being very, very chronic if it's not dealt with.
Yeah, definitely. I think if anyone's got saddle sores and you see anyone in clinic that's got saddle sores, it's really important to know if that's at the first instance of them, because once they've become chronic, it may be that, you know, that the epidermis appears healed, but actually the deeper layers may be affected. And as Tim said, you know, steroid cream seems like it will resolve the issue. And it can certainly help calm the symptoms down. But once you have someone who's been on repeated antibiotics and repeated steroidal cream, changing the saddle is not necessarily going to alleviate things straight away, nor is changing the position. And so you've got to balance the expectations. And it may be in some cases as well that you need to refer them to a dermatologist for review, because this person has to know that, you know, if it's at this stage, it becomes far more difficult to manage, for sure. In terms of like coming back to what you were saying, Ove, about the kind of blood flow and stuff, what other symptoms might you get, do you think, in the pelvis that are associated with like vascular pathology?
Well, I guess the numbness that you're getting is partially from that. There's obviously a neural part of the vascularity too, so the blood flow to the nerve is affected, which again causes further problems down where you've probably located that into the neural-based pathologies. There is a slight crossover there, but in terms of the saddle position and things, I think it's mostly the actual blood flow into the penis, and I was going to discuss this further, I think, on the case study 3, but I can go through some of it now if you like. So the blood flow itself is massively reduced, which when you don't get the blood flow into the tissues, they don't get the stimulation, and that's quite a simple thing, like a use it or lose it kind of scenario. And what actually happens is that you get a collagen synthesis within the trabecular system of the penis, which makes it less extensible. So you actually have a lesser chance of actually getting an erection with long-term reduction of blood flow into the tissues. And what I find is really interesting is that the typical person who comes to me for treatment for ED, for instance, they're overweight, they're a smoker, they're sometimes a diabetic, which have all problems with getting blood flow in there. And the cyclists that get it, they're not any of those things. But what they do share is that reduction in blood flow into the penis. And so there's a pathological change that happens within the structure of the penis because of lack of stimulation. Interestingly, one of the things that they talked about to actually stop this from occurring is taking things like Viagra or Cialis to prevent any long-term damage from cycling, which seems a bit strange when, if with the proper positioning and maybe the proper saddle, you can actually prevent all these things in the first place.
Oh, that's interesting, Uwe. I guess as well with like a lot of the neural-based pathologies, you can experience similar symptoms, as you say, to the vascular-based. So you can get just generalized pain from the pressure. But you can also then sort of range that up to pudendal neuralgia or pudendal nerve entrapment esque symptoms. So there's lots of things that overlap here, and arguably you want to know what the symptoms are, but we don't necessarily need a firm diagnosis to start with, because I think this is where, if you do have someone and you've got good outcome measures and you can see what are the issues and do they relate back to that saddle pressure mapping, for example, which I think is just such a crucial part of seeing someone on a bike fit with these problems. You can then just work out if taking the pressure off resolves the symptoms. Great. Is the solution as simple as that? Or is it that, we have to think about the sort of off the bike management, really, and thinking about, sending people to clients or professionals like yourself, Uwe, who may need to address these things off the bike, really. So, moving on. So we thought maybe we'd try and put some of this stuff into practice and just talk about some case studies that we could bring to the table. So we've all kind of got some examples here, but one of them, this is an example of a guy that I saw. So this guy came in for a bike fit and he was complaining, and you can see on the left was his initial position. He was complaining of quite extensive discomfort in the perineum when he was cycling, and this would build up over longer rides and consecutive days of riding. But actually, if you look at his position and we sort of think back to those normal values that we just spoke briefly about at the start, generally things were actually pretty much in range. The most notable thing actually was his pelvic position. So note, just from looking at the red line, there's a hinge. So there's a hinge just sort of around the mid-lumbar region. And this hinge meant that his pelvis rolled into some relative posterior pelvic tilt. And this was enough to sort of link back to what Uwe was saying about actually sometimes the pelvic position being a little bit more upright may actually cause an increase in symptoms versus being in a different position. But sometimes the saddle choice just really is not right. And in this case, it was literally just the saddle and some shoes. So changing the shoes and changing his foot position allowed us to reduce some of the forces that were occurring at the saddle and causing him to posteriorly rotate, but also changing the saddle just to one with a small cutout that had quite a nice flat supportive section, just allowed him to roll forwards. And it seems counterintuitive. You think, yeah, but if I roll forwards, should the pressure not get greater? But it really doesn't always. And this became a far more sustainable position and actually just was enough to alleviate those symptoms that he had, really. So that was quite an interesting one, because it's not your typical kind of go-to choices to start with, thinking about the feet, but they have a huge role in pelvic stability and in pelvic pressure. There was another one here. Now, Tim, have you actually seen anyone post-prostatectomy, or Uwe?
I've not seen them for ED. I do get plenty of people with having been through that surgery into the clinic, but not usually with any pudendal pain or perineal pain or anything like that. I haven't seen any of those yet.
What about yourself, Tim?
Yeah, only not acute. So I've seen people further down the line, but no, I haven't actually had anybody come through acutely post-op. But it is obviously something that has had to be taken into account for people who are maybe a little bit further down the rehab, or even sort of several years post-surgery.
Yeah.
Still very sensitive, maybe some
Yeah.
some discomfort still going through that area. So the idea is finding a position and a saddle choice which just almost removes any kind of contact point around the perineum and obviously the prostate.
Definitely. I think this is a really under-tapped area, actually. So, I mean, it's probably not something that we'd be a first contact practitioner for. I'm sure there are many of you listening that are pelvic health physios that have far more expertise in this area than perhaps we do. But what we do have is the skills, again, to think, okay, what's the anatomical area and what are our goals? Well, they're to offload the perineum and any soft tissues potentially. So this was a really interesting study that I was able to do, because a urologist actually recommended a gentleman attend following a prostatectomy, but he still had some ongoing issues, which is why the consultant said, look, I'm happy to make a deal with you. You can return to cycling as long as you make sure you get a saddle that's appropriate for, the fact that there's still some things that we're looking into and investigating. So this is an example of the Dubai-Myers pressure mapping that I was referring to earlier. So Dubai-Myers being one of the brands that exist on the bike fitting sort of biomechanics market. And this would be a top-down view. So this was his original saddle. Now, anyone that's seen saddle pressure mapping before will see that actually this isn't too bad. Generally, if you think back to the research study that we were mentioning earlier, how that some males may load the sort of I guess, if you like, more on the middle to the front of the saddle, because their bony loading is such that that's where they'll generally tend to sit a little bit. In this case, some of the kind of obvious observations were that there wasn't even pressure on the left and the right side. There was more pressure on the right-hand side. And generally, he tended to sit off to that side a little bit. But actually, if you look through the centre, there wasn't actually a lot of pressure. But if we think back to this guy's anatomy, although the central channel had quite a lot of pressure reduction, actually the borders up to that were quite tight. So we tried a couple of saddles and we tried playing around with the position, and we were able to try something called the Rido R2. Now, for any of you who have heard of these saddles, you'll realise they're quite an unconventional saddle. They're very wide at the rear and they generally have a nose that has a great stack difference compared to the back. But actually, if you look at the pressure on this compared to the original saddle, it just distributed more of it onto the rear of the saddle through those sit bones. And so we ended up with this lovely big circle of pressure reduction in the middle. So this was a potential contender. The only thing about the Rider is that for him, he wasn't perhaps so stable on that saddle. And we can see that from the black trace on the screen, which you might not be able to see so clearly, but it's under the red line. So then we tried a Cell SMP saddle, which there's various models, but one of them being the Plus, and it's the wider variety. So again, not sort of your sort of conventionally symmetrical saddle, but if you see again in the middle, there was a nice kind of circular space, which was just perfect. Because if you think back to this one, although it was quite good, he was quite asymmetrical, and the borders, as I said, came up quite close. So for him, it just meant it overlapped on that anatomical area and caused a little bit of compression. But for this, he can now ride for miles, he can ride on bumpy terrain, and there's just a sufficient window there, if you like, of pressure reduction to allow him to be able to do what he wants. So this is a pretty interesting one. But obviously, these Cell SMP saddles have had quite a lot of research done by the manufacturers into like blood flow, for example. So it comes back to what you were saying, Ove, about trying to enhance blood flow, etc. In those sensitive anatomical areas. This is probably one now more for you, Uwe. Some case
Yeah.
studies. So put up.
Well, it's one of those things, isn't it? Symptoms of ED is very simple. It's the inability to get or maintain an erection in males, and for the general population, once you hit 40, it starts to become a little bit more prevalent, and it's quite a normal thing. By the time you kind of get to 50s, 60s, you're more likely to have it than not have it. And it kind of goes up to somewhere between 40 and 70 years old. You probably half of adult males have that. In terms of cyclists, then, so we mentioned it's about somewhere between 6 and 13% of people who've done long distance ride that kind of get this. But what we also know is that there's an independent risk factor here, where if you cycle more than 3 hours per week, then you're much more likely to get both moderate and severe erectile dysfunction. So we touched on one of the reasons before, which talked about the blood flow and how that causes the lack of extensibility from disuse within the penile structure itself. But the other thing, which is also very, very important, is the neural compression that occurs. So the neural compression is quite significant in the perineal area, just underneath your pubic bone. And we know that even 5 minutes of pressure in there, there was a trial that did this, and that could already cause numbness after only 5 minutes. And it took 15 minutes for that numbness to abate after it came on. And having been a cyclist myself, certainly with different types of saddles, and I've had very similar things happen myself. Wasn't the reason why I got into this, but certainly there is a decrease in signaling, so neural signaling, and that then has an effect on the release of nitrous oxide. So the nitrous oxide causes a relaxation within the smooth muscle tissue around the blood vessels, allowing the blood flow to actually come into the penis. So with decreased signaling, you won't get enough blood to actually get an erection or maintain one. One of the reasons why is because it doesn't occlude the veins enough, and you get venous leakage within that structure. The second thing, and this is something that also is involved with the prostatectomies. Prostatectomies technically have a lot of neuropathy or neuropathic problems afterwards. And they could potentially have this same issue where they just don't have enough signal in there, and erectile dysfunction for them is very, very common for a similar reason. So you don't get this smooth muscle relaxation, and again you get this connective tissue synthesis within the smooth muscle tissue, which again makes it harder for them to actually let go and relieve some of that or the tension in there. So there's lack of blood flow again. So that's kind of the two main causes of erectile dysfunction within cycling, I guess. And the two papers that I've mentioned here, one of them is the bicycle riding and erectile dysfunction. I wanted to kind of introduce this topic to you guys. So in terms of the two papers there, one of them is just generic. The first one was the one that was put on there. It's a generic paper on erectile dysfunction. Just to understand the differences between a neuropathic one to an endocrine one to a vascular one. And vascular is kind of considered to be the more organic version, which concerns most people as they get older. So, but we know then that the numbness is quite significant, and there's studies there that shows that about 61% of cyclists would get numbness during a long distance ride. And out of those, or out of the entire population, there would be about 24% of them that would also develop ED. And the significant thing there was that there was no cases of ED that didn't also have the numbness involved there. So it seems to be quite a big factor. So go on.
Uwe, yeah, so Uwe, let's say, for example, this leads nicely on from the previous case study. Let's say, we had this guy in, he's had a prostatectomy. We've done what we can on the bike. We've taken the pressure off, anatomically. We've optimized without obviously measuring, but we can say safely that we've taken some pressure away. We'll have improved his blood flow. what happens if his symptoms persist or he's having numbness, etc.? What would you do if we sent him to you?
So there's two ways of looking at it. It's much more complex than just one thing. I think establishing a normal pelvic floor function is really, really important. So pelvic floor muscle training is very, very important for these people. The prostatectomy people, they tend to have a really, really slow return, and they often have other problems with their external urethral sphincter, for instance, and they have micturition and stuff, and other associated problems which can be quite complex, really. So they're not an easy case. But certainly the pelvic floor function seems to be a really, really important thing, both for them to establish a normal function, both in terms of urine and fecal continence, as well as the erection side of things. Interestingly, there's a urologist in London at the moment. He's because of this neural damage that happens, he's now shockwaving his prostatectomy cases straight after surgery, and within the first week, to try to re-establish function within the nerve, which is the next thing I wanted to talk about. So obviously, in terms of trying to improve these things, one, you have to go with the pelvic floor function. So if you can start to engage the pelvic floor, which is really, really important, and that's the other part of the pudendal nerve. The pudendal nerve supplies the bulgiospongiosis, and the other one is the ischiocavernosus, which basically create pressure around the penis at the bottom so that you actually get the venous occlusion, and with that you can actually improve your erectile function massively. But it's about 20-25% of people that don't actually respond even to the pelvic floor exercises, and for those people you need to then look into other things. So the alternatives are medications, like we mentioned, Viagra, Cialis, sildenafil. The next step from there would be to do injections within the penis to create the blood flow into there, or relax the muscle tissue enough to get blood flow, and then it progresses from there to penile implants, which is obviously an operational and that you need as well. So this is where kind of the shockwave comes in a little bit, and if I can just explain how I got into it, these people, they kind of get to the end point, or they get so desperate eventually that they start looking for just about any solution. And so I've been doing shockwave for years, and I was approached by a client wanting to have this treatment, and that's when I decided that I needed to get better educated on these things if I was going to help these people. I have a terrible condition. It's called not being able to say no to people if I can help them. And so I started then looking into things, and luckily I'm now one of the tutors for Storz Medical within this country through a company called Venn Healthcare, and they had me on a trip to the factory in Switzerland where we got trained in various areas of shockwave by their experts. And one of the things we actually got trained in was the protocol for ED. And these things kind of happen very much at the same time. And so I treated them, and we had great success, which was good. But that was kind of how it all started. And then by the time you've seen a couple of these clients, you realize how complex they are. And you then realize you need more education than that. And so we've been on men's health courses with Gerard Green, who's a great men's health physio. He's based near you in Birmingham, and learned so much from him. And taking that complexity into this has been a game changer, really, because they have, the traditional ED case can be quite complex. So in terms of then shockwave, what shockwave does is basically a low intensity audible pressure wave that goes into your tissues, which then creates a few different changes. We know that it can help with nerve regeneration. So it stimulates healing processes in different types of cells, fibroblasts, even in bone, osteoclasts. And some of the things that it produces is the nitrous oxide. So we mentioned nitrous oxide being so important for relaxation of the smooth muscle tissue and allowing blood flow to happen. So we then have a treatment that can actually do that without any complications. There's no side effects to the treatment, and is non-invasive. The second thing that it does is the stimulation. Like I said, it creates a activity which then creates a healing response, and we found that it can help the smooth muscle tissue function better. And on top of that, we have the nerve regeneration, which it can do as well. So we have a really, really good option in terms of the people on medication, the people who are having the injections and such. And we know from the research that it's effective in terms of improving these people who are now left without an option after doing the exercise-based interventions. And what we found is that, or what they have found in the research repeatedly, is that if you are taking medication, it will take you off the medication. If you're having injections, it will take you away from the injections back into the medicines. And sometimes even when medication doesn't work and the injections work, it can take you completely off all of it as well. So it has been shown to be tremendously effective, but it's kind of the last line of treatment. You want to try to improve their function first and foremost. The other thing about numbness that I didn't mention was that they did this study, obviously showing that the compression can cause neuropathy, and they also looked at how they can rectify that. And one of the measures that they looked at was taking a saddleless or noseless saddle, and within 6 months of just putting a noseless saddle on and continuing their cycling, it actually returned back to normal again. So you have to kind of look into, I think, both, like you said, the bike positioning. You've got to look into the function of the muscle and try to re-stimulate and re-energize that area, because the lack of stimulation could cause issues in both the short and the long term, I think.
Yeah, definitely. I think that touches on some of the options out there that are available, because you have that Rido saddle that I mentioned and the Cell SMP saddles, which can be perhaps on one end of the spectrum. They're not your conventional saddle that you might choose initially, but if you are having problems. But the same for brands like ISM, they're the typical noseless saddle. And they are actually patented because the nose isn't fixed. The nose has got two prongs that are unsupported. And actually, some clients say it's the flex in the saddle that actually helps with the pressure. So you might lose a little bit of stability, but if your issue is pressure-based in the first place, then you take that away, and then you ultimately have something that you can ride in. So if any of you, I think, seeing patients, there's some good go-to saddles if you think their saddle position or their bike position is quite good. But Ove, so if you have a client that presents to you and their symptoms are quite chronic, how effective is Shockwave for those?
So most of the research will show you that it's kind of in the high 70s, so 70-75% success rate with severe cases. But like I said, it tends to the outcomes are basically based on two things. One is the international index for erectile function, which categorizes you depending on how well you're functioning. Then they also looks at the hardness. So there's something called the erectile hardness scale as well. Okay. And so you tend to find that people who are unable to get an erection that's enough to have intercourse with, which is what it's about, I guess, then you will be able to do that. And so dependent then on the hardness is whether they classify it as a good or a great outcome. So what they found is that 75% of people have a good or a great outcome, and that may be that they've got enough blood flow in there and maintain enough function to have intercourse, but they might not be as hard as they would be, say, in their 20s or without the problems that they used to have. But the success rate is relatively good with Shockwave.
Ove, are you the only one in the UK that's actually delivering this then?
No, that there are several companies involved, and traditionally this has been done by neurologists or men's health clinics. So the cost of this can be quite extortionate, and in some cases up to about £3,000 for a course of treatments. So basically what we sat down with, we're a group of teachers of Shockwave, which all have an interest in using that modality, and we've all been individually approached by people to help them. And so we sat down as a group and thought, well, how can we do this better? And so we've partnered up with some doctors. We've partnered up with there's 5 or 6 clinicians now across the UK. So we kind of cover most of England. You know, we have somebody in Southampton, we have somebody in Birmingham, we have somebody in Norfolk, London, and me up in Yorkshire. And we've kind of decided that we want to provide a good service. We're all trained in the men's health area now. We're all highly trained in shockwave, and have multiple years worth of experience with that, and we're then trying to drive the price point down. So at the moment we're around about a third of the cost of the traditional clinics that are providing this treatment. And you know, the equipment is expensive, which is one of the reasons why the cost is there. So that, you know, a lot of people have a shockwave machine in their clinic, but there's a difference between the different types of shockwave. So you have a radial shockwave, which is an impact-based radial shockwave, if you like, and then you have the focus, which is a much higher energy device, and all of the research has been done on the focused shockwave, where radial has kind of not been looked into because it doesn't create the changes within the nitrous oxide, etc. So all of the research pointing to the results is all about the focus. So the focus machine is nearly triple the cost of a radial machine, and so you're looking at an investment of somewhere between 25,000 perhaps into your clinic. And so my clinic invested in it because I wanted to be able to treat more advanced pathologies within the sports field. But then obviously when I've been approached with other pathologies and you think, well, maybe I can help these people, I saw it as a great opportunity because these people are very much, like I said, underserved. They don't really have anywhere to go once they get to the end of the line with the urologists. And this is a really nice and easy treatment to do, which takes about 20 minutes, where they can have 2 to 3 treatments per week at the most. And you go on for 2 to 3 weeks, or in mild cases, you might have 1 per week for 6 weeks, and the results are very similar.
Great, thanks for sharing that, Ove. Yeah, it sounds really interesting and like a good option for people who might not have found traditional methods help them. We did have, I think, just bear with me, the computer has just gone through. In terms of us talking today about some of our content, sorry, excuse me, this is just gone slow. We've obviously gone through some scenarios, but not necessarily covered them in depth. I know some of you asked some questions around like the shoes, and what was the shape of the shoes and what were the insoles and things. It's probably a little bit in depth to go into that right now within this with this talk, but we do actually have another webinar that's going to be scheduled for next month on the foot. So maybe you could join us for that and we can talk about that in a bit more detail. But Tim, have you got any other examples or kind of discussions that you want to have whilst we're on for the moment? Or do you think we kind of covered everything really?
I think we've covered the main points we wanted to go through. I'm conscious that we're about to approach the 1 hour mark, so keep people for too much longer. A quick scan through the questions that were coming through on the chat box there. The main thing is just to get people talking about it. And so if you are a therapist dealing with cyclists, or if you are a bike fitter, is make sure you have that conversation and get comfortable having the conversation with both your male cyclists, like we're talking about tonight, but also your female cyclist, in that, are you getting any problems on the bike? Because you shouldn't be getting any numbness. You shouldn't be getting any erectile dysfunction. You shouldn't be getting saddle sores or any of the other sort of symptoms and conditions that we've talked about. I see Paul put a message there saying you have a symptom checklist used to screen for pelvic pathologies when you've got a client coming in for just a standard or performance-related fit. Well, my answer to that one is just have that conversation. So on my pre-fit screening form, I ask the question, do you get any saddle problems? And do you get any numbness? Do you get any pins and needles? Do you get any soreness? Do you have any dysfunction in any way, shape, or form? So sometimes you'll get somebody coming in and you ask, any problems with the saddle? Oh no, it's fine. So you never get any numbness or any pins and needles? Well, yeah. After a long ride, yeah, my penis goes numb for 15, 20 minutes, but that's normal, isn't it? No, it's not normal. Right, then you start that conversation and you start exploring it a bit more. So I think the short answer to your question there, Paul, is have that conversation. So Bianca, do you actually have a specific checklist you would go through in your fitting?
Yeah, I do, and it depends on the individual. Paul, it's not something that's in a shareable format right now, but I'm currently working on a project to sort of release a tool, if you like, that will allow you to go through some common issues and then just to troubleshoot what to do, because everyone that's probably joined us tonight has come from a different slant, and we're physios, we're going to ask things that are different because some of that's part of our training, and we need to identify what we call red flags. But for those of you that don't come at it from a physio angle, you're going to have a different bias and a different, I guess, if you like, priority. But what we kind of want to stress really as part of this is make this a priority, because if we think back to that article that we mentioned at the start from Lieberich and Moore, they found on that review that 50 to 91% of people have some form of pelvic issue on the bike. It's non-discriminatory. It affects males and females, and a lot of people just assume it to be normal. And if you just literally ask the question, do you have any problems with the saddle? It's not enough. You have to delve deeper for sure. So a bit of a convoluted answer to your question, but watch this space and we will be able to help you. But if not, what you could do is just look at what a lot of pelvic physios do. So they really have got a lot of research into what's normal, what's not normal. If someone's presenting with this, where should you refer them, etc. So there can be some good sort of pelvic physio resources that exist out there.
As it builds your network of contacts, so that as we walk today, so if you have somebody who has chronic problems, have a network of pelvic health specialists that you can then refer to. So I'm up in the north, so for me it's Ove, or wherever you are in the country, have contacts, have a network of practitioners you can then refer to. Do you want to? There's another comment there from Daniel about, would you recommend time off the bike for everything to settle down? So things like through the dermis and the epidermis. So
yeah, I think traditionally, Daniel, like people will have 2 or 3 days off, and then superficially tissues might have healed to an acceptable tolerance to allow someone to take pressure on. And if you sit back on the bike for 5 minutes, it feels fine. But the issue with this is that really you need weeks, if not sometimes months, off the bike, and that's what people aren't prepared to do, which is why you need to stop it getting to that point in the first place. And sometimes someone's going to do it regardless, and you can advise them. But if they want to ride, they'll ride. But I think as long as you sort of realize that sometimes 1 week, 2 week, that ain't enough. But this is where if you do have suspicions that there's something going on that's a little bit more than just your normal saddle sore, dermatologists can absolutely be worth their weight in gold to help you and to spell out that situation as well to people sometimes.
I say it's just appreciating maybe how deep that irritation or damage has gone. And if it's just the skin, then maybe 7 to 14 days is enough for that skin to recover. But if it's deeper tissue than that, then as Bianca said, you may well be looking at several weeks at least for that deeper tissue to recover, or if not, much, much longer.
And in some cases as well, your tissue may actually require medical management because perhaps it's scarred, and the properties of that skin and the properties of those deep layers just don't function in the way that they might have normally. as a result, you may have residual swelling, etc., that you just can't shift by rest.
Okay.
Cool.
Okay. Any final comments? Ove, is there anything else that you wanted to add in, or?
No, I think I've covered most of the things that I wanted to speak about this evening.
Share your we've got obviously our branded contact points there, but do you want to tell people where they can find out a bit more about you?
I guess I have a pretty unique name. If you wanted to Google Ove Indergaard or my clinic, which is Indergaard Physiotherapy, you'll be able to find everything that we do there. In terms of the erectile dysfunction network that we have, it's the ED clinics or pelvic pain as well. edclinics.co.uk, and that's available on Instagram and on Facebook and everything, wherever you have your social media fix.
Great stuff. Thank you very much for joining us this evening. It's been good to have you on board and again build the network of practitioners in this field.
Definitely. If you want to get in touch, feel free to ping us some messages on the social channels, and we can get back to you. Or if you need some support in trying to find a practitioner to help you, let us know. But otherwise, thanks for listening.
Great stuff. Thanks very much, guys. See you next time.
Cheers.